So my presentation will be about centering school-based health centers and global health discussions and interventions. As a quick introduction about me, my name is Rikhil Ranjit. I'm from Alliance Academy in Georgia. Some activities I'm involved in, I'm a part of the School-Based Health Alliance Youth Advisory Council, which will be more relevant as I go on in today's presentation. I'm a public forum debater. I do some research also related to school-based health centers. And in the future, I'm hoping to be in some career related to health policy or law, or maybe an intersection of both. Beginning with some context for this presentation before going into the nitty-gritty of it, the key issue right now with healthcare affordability in America and across the world is that with over 800 million people, 10% of their spending is on healthcare, and half of the world, according to WHO, can't access essential health services. Either people have no insurance, they're underinsured, or they can't access actual healthcare that should be a human right. And part of the reason why this is the case is threefold, according to Harvard, that isolated three main factors as to why this industry has such flaws. For example, number one, the industry is entirely profit driven, is what Harvard argues, suggesting that when it comes to things like innovating new drugs, pushing for R&D, these pharmaceutical companies always upmark costs over the justification that they need to innovate new drugs, but instead spend a lot of this money on marketing, advertising, rather than actually making breakthrough drugs that every single person needs. The second issue and the third issue are kind of similar. It's about pharmacy benefit managers and cost sharing. Essentially, when it comes to insurance companies and these small third party negotiators called PBMs, these are the people that determine your insurance costs. So they're able to negotiate with pharmaceutical companies, and every time that they have to pay some sort of money to insurance companies, they pass that cost down to the consumer. And another issue that I think goes largely unaddressed is the issue of transportation in rural areas. Because according to the USC, in rural areas, they have to go 40 miles on average to access things such as cancer treatment services compared to just 15 miles in urban areas. So all three of these issues, along with some other factors, are the key primary factors that have caused healthcare inaccessibility. The reason why this pivots really well to the discussion of school-based health centers is because of how simple and innovative the idea is. Essentially, school-based health centers are health clinics within school grounds, as the name suggests. So there's actual healthcare services, doctor checkups, primary care services that are easy access for children. And we'll get to the benefits a little later, but just for some context about numbers, there's over 3,900 school-based health centers in the United States alone. And the issue is there's very little discussion about these health centers specific to global health intervention. And you'll see in these two examples here with India's health promotion schools that didn't really pilot school-based health centers, but tried to disseminate information, facts, areas to access health centers in these schools to take a step forward to see if there's any demand or interest in actually creating health centers and services in school. In Cape Town in South Africa, they had a 20-week pilot project where over 340 students in the University of Cape Town were able to access school-based health centers. And the data for this is quite unclear because the collection of the data wasn't necessarily perfect, but it does go to show you that the idea and viability of health centers is slowly growing. Speaking of what SBHCs provide, it's essentially anything you can think of when you talk about a healthcare provider. For example, health centers have recently shifted over to telehealth during the COVID pandemic to try and provide flexibility for families. And some other services that they provide for different students. I think this graph shows really well. These graphs are all data from Cincinnati, which is a pretty largely robust school-based health center system slash framework that a lot of other cities and states are looking to apply if they're interested in school-based health centers. But just for some numbers and rundowns, you can see that primary care visits from 2014 to 2022 have increased. That's because 65% of all services provided by school-based health centers are primary care specific. According to the ORS Impact Research Study, you can see that school-based health centers really don't have any restrictions when it comes to what they can do. For example, with depression screening, vision users, chlamydia screenings, the list goes on. The SPHC difference, the reason why the graphs are so high and the usage rates of these services are so high when they get incorporated in schools is number one, the access is very easy. We discussed transportation barriers before. There is no transportation barrier for rural areas as long as they have access to that public school right next to them. So the health access that we're talking about is all within this school. And what makes this especially beautiful is because there's no stigmatization that happens with services. Part of the reason why students and families don't necessarily want to access some sort of community health center, whether it's for a mental health issue or for drug screening, is because there's a stigma surrounding it that makes it feel like going there will make some individual ousted, which immediately goes away with health centers because these health centers are not only anonymous, but they're within the school. And because the access is so easy, some studies have suggested that students are 21 times more likely to go to a health center than a community health center, as long as that health center is located in their school. And another part of a health center that kind of goes unrealized is it creates rapport, because now you actually know the faculty, you know your doctor, you know who you're getting your care from. And since they're all right next to you, it makes it so much more better. Another part of this is cost cutting. A lot of schools have taken it up on them for families that are especially uninsured or underinsured to try and figure out the situation for them, get them access to government sponsored health insurance, whatever is necessary. And there's also other integratable options and frameworks. For example, SBIRT, which is specific screening for drug prevention. So they'll screen students to figure out if they're more likely to go to illicit substances, and based on that, they're able to get the necessary screening and counseling that they need to ensure that they don't go into a rabbit hole of vicious cycles of addiction. To kind of take this generalized argument into actual numbers and what this impact positively looks like, there's a lot of data, for example, from Emory University suggesting that just the adoption of school-based health centers increased dental visits by 6%, which suggests that with school-based health centers, you're getting more people into health offices. A second one, which is a very important one if you're looking at school-based health centers economically, is its net benefit. Most investors actually prefer having school-based health centers and are fine with investing in it, because even though it does cost 16K to 660K per year, the social benefit long-term is so high. According to Emory, 1 to 38, 3.05 to 1, the benefit ratio is so high that it is worth it for them to invest in these initiatives, which makes it a lot more feasible for it to be implemented across not just the US, but across the world. And obviously, because there's more health benefits, as you can see at the bottom, because of Harvard University study, more SBHC saw a 29% decrease in high school non-completion rates. More healthy students simply means more people staying in school, getting educated. And another very important aspect of school-based health centers is who it actually targets. And what this data from the Clemson University suggests, with a standardized mean score of less than 0.1, it mainly suggests that the people using these health centers are people of low-income background, as you can see on the right, people that are already getting access to things such as free and reduced lunch. Some of my involvement in this research, some of the data you saw previously is some research I've done with UGA and independently, especially with some work I've done with SBIRT screening in association with the Youth Drug Council. I've worked with professors to talk about school-based health centers with rural areas and pandemic prevention. Legislatively, I'm trying to push SB82 legislation in the Georgia General Assembly to address greater healthcare affordability and try and make it more entrenched to ensure that Georgia's healthcare is a lot better than it is right now. As some acknowledgements, I'd like to thank the professors, the School-Based Health Alliance, and the GHLC for providing this opportunity. Here are my references. Thank you so much for watching. If you have any questions, feel free to contact me in any of these information, emails, LinkedIn, etc. Thank you so much.